Well, welcome everyone to the McMaster Midwifery Research Center speaker series. This is a series of regularly scheduled rounds that are open to everyone, where we hope to share the latest midwifery-related obstetrical and perinatal research. My name is Dr. Ginny Brunton. My pronouns are she, her, and I'm one of the scientists of the MMRC. Please do ensure that your Zoom mics are turned off today. And note that today's presentation will be recorded and we'll have it up on our website soon for you. Moving on to a land acknowledgement, I just want to say that today I'm coming to you from the traditional lands of the Mississaugas of Scugog Island. I feel a deep sense of gratitude for the Indigenous stewards of this land. As a settler, I'm mindful of my responsibilities to live in harmony with the original peoples of Turtle Island and with the land. Beyond my gratitude, I'm also committed to actively listening, learning, and unlearning the narratives that have shaped my understanding of this land and its peoples as a step towards truth and reconciliation and the ongoing process of decolonization. McMaster is located on the territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. I'm very pleased to welcome our speaker for today, Manavi Handa. Manavi Handa is a registered midwife and associate professor at Toronto Metropolitan University. For more than 2 decades, she's focused her clinical practice, research, and advocacy on equity in healthcare, especially documented and undocumented refugees. Her research was used as the foundation for some fulsome provincial funding for undocumented or uninsured people in Ontario midwifery care. And her work has been recognized through the Urban Alliance for Race Relations Award, the Iewirokwas Cape Award for Midwifery Heros, the Planned Parenthood Reproductive Choice Award, and the Association of Ontario Midwives Excellence in Midwifery Research Award. Her talk today is entitled Midwife Mondays at the Non-Insured Walk-in Clinic, Demographics and Trajectories of Care for Medically Uninsured Pregnant People at a Toronto Clinic over a 10-year period. So welcome, Manavi. Looking forward to it.
Thank you so much for that kind introduction. So I'm just going to share my screen. Just want to double check that you guys can see. Yeah, okay.
All good.
So I'm going to talk about the non-insured walk-in clinic. We're in the process of doing a 10-year retrospective chart review, looking at 2012 June to 2022 June, at all of the clients that we've seen over a 10-year period. And this is the preliminary results of that study. Oh, that's weird. My screen is not advancing. Oh, now it is. Okay. So I'm just going to talk a bit about the non-insured walk-in clinic. I could do a whole presentation on how to set up clinics with different versions of midwifery scope. And I think that that is an important thing to look at across the country as people are trying to serve this growing population, but I won't get too much into the weeds of that because I want to talk more about our findings. I'm going to talk a bit about undocumented refugees and our current context, and then really the findings of the study, which what we're looking at is demographics, trajectories of care. So where do people get referred to and why? What their risk status was by midwifery assessment and how we categorize different risks, and what the complications are that we've seen at the clinic. And then I'll just tell a couple of minutes of stories at the end just to illustrate and give some real life behind these statistics. So the non-insured walk-in clinic was developed in partnership with 7 community health centers in the west end of the city. And it was in response to growing community need. So the target has always been the northwest corridor of Toronto with, some of the most impoverished and densely populated communities in all of North America. But we do serve anybody in the city of Toronto. It started in partnership with one midwife, meaning me, and it's because my practice group at the time, West End Midwives, was in the same area, and so we had had some referral arrangements in the past. Our agreement and the work at the non-insured walk-in clinic is in like initially was informal. Phase one, so the first 5 years there was no funding. It was volunteer midwives, so I basically just reached out to all of the practices serving the west end of the city and said, listen, like, there's nothing on paper, but can you prioritize this population if possible? Um, and I have to say, a big part of what has made this successful is midwifery practices taking referrals. The biggest part of what's made it successful is, and I realize this in retrospect, it's that the practice where I work is also the same area where the uninsured walk-in clinic is. So about 80% of all of our clients go to West End Midwives. And really, you need a strong relationship with a practice to make that happen. So the first 5 years, I was there most of the time, but we had a whole roster of volunteer midwives um, because there was no funding. And then phase two, we were funded through a Schedule Q at our midwifery practice. I should mention that the clinic is nurse practitioner led. So initially it was all the nurse practitioners' requisitions, and we had a series of midwives. We'd use their requisitions, they would do the follow-up. As we got bigger and more established, there were more concerns about potential near misses just because the knowledge base with the nurse practitioners versus the midwife was quite different. They are not as familiar with perinatal care, especially newer norms around perinatal care. So things like placental markers or what an okay thyroid value is, those kinds of things could stump the NP sometimes. And so um, the next phase with the Schedule Q was a nurse practitioner and midwife-led clinic. It's all midwifery requisitions. Then it moved into just being me, unless I was on sick leave, and then I would pay other midwives to step in for me. But that was with funding, less funding over time. So it started kind of based on a 4 to 8 hour a week model, and it grew to being much bigger than that. And then the last phase since April 2023, it's now midwifery led. We have our own requisitions through the Community Health Center, and we're funded as an expanded midwifery care model. And I can get into what we do and how we do it, but I'm not going to go off on that kind of tangent. I want to talk a little bit, before I get into some of the findings, I just want to remind us a little bit of the context around undocumented refugees. And I wanted to talk a little bit about language, and I'll get into that in a second. So some pretty grim global statistics. There are more people displaced globally than ever before. The most recent numbers are that there are 108 to 112 displaced people globally. That number is actually increasing by the minute, sadly. Right now, there are approximately 1 in 69 people on the planet who are displaced. And I really, having been a front line on this story in the Canadian context for the last 30 years, given increasing global and economic disparity, health disparities, security, climate crises, I just don't see this trend changing. And we're seeing kind of countries all over the world grappling with this same issue. The minimum estimated number of uninsured people in Canada is 500,000. Some people estimate it's closer to 2 million. A recent Globe and Mail article just published in the last 2 weeks, and I didn't reference appropriately. I apologize about that. But they suggested there's up to 4.9 million people living in Canada with temporary status. So we are talking about hundreds of thousands, if not millions of people in the country. If you just do the math, if there's 1 in 69 people globally displaced, and we have a population of around 41 million in Canada, that gives us 594,000 people. So the lowest number we're looking at just statistically is probably around 600,000. Canada is also considered what is called a high migrant receiving country. And so we probably have a much bigger number than that. And, certainly on the ground, it feels like this groundswell that is not like a tidal wave that is just not getting any smaller. I think it's really important to also understand that high migrant receiving countries that are grappling with the same issues from, birthright citizenship, which is very hotbed right now, all the way to uh, how many people should be allowed in, what their status is, undocumented people. That high migrant receiving countries are countries like the United States, the United Kingdom, France, Canada, Spain, Australia, also the UAE and Russia are in there. And we have to remember Russia as a major colonial power in its own right, even though we don't think of it in terms of British and European colonialism. But really, aside from the UAE, we're talking about countries that were the seats of colonial power and wealth. And I was going to play this clip, but I won't. But it's a clip by a comedian named Trevor Noah talking about in England, like why, like how they're shocked that so many people are showing up. And he was like, "You told us about England. You said it was the greatest country in the world and it had all the wealth and all amazing things. We didn't know about this tiny island, but you went all over the world and told people how great it was. So guess what? Everybody wants to be there." Um, I do also think maybe this is a little bit of just karma. Like, we are not one of the wealthiest countries in the world by accident. We are by design. There was a time when 90% of this planet was owned by colonial powers, 75% of that being the United Kingdom. And so I just think it's really important because it's so easy, especially with the narratives we've been hearing, to somehow think that we are here because of some inherent privilege we have. We are here because we were born here by accident. And that is true for anyone on the planet. You're born where you're born. It's not that you inherently have a right to a country that is based on stolen land and displaced wealth and displaced people. So a little bit about why there are so many uninsured people. Historically, there've always been some that are uninsured. Those were generally and still continue to be, and these numbers are also rising, but people who are kind of at the margins of being street affected, having addiction issues, maybe mental health issues, poverty, and who might not physically actually have documents or up-to-date documents. That population has always been there. It is growing. There have always been obstetrical tourists. This is really also considered a red herring. There's so much talk about obstetrical tourists that's really detracting from the overarching issues. Really, the global elite have always traveled for healthcare and they always will. I don't think that we can change that. I think our discussion about, all of these people coming here just to have a baby. I've never met anyone who's come to Canada for the weather. I don't think that's been true for hundreds of years. People come here for a better life. And if they're coming to have their children here, even if it's to return home, it's for the promise of a better life because wherever they're coming from, either lack security or climate stability or political stability or economic stability or all of the above. We also have this huge growing proportion of what we consider newly uninsured or undocumented. When I say newly, I'm talking about 25 years at this point. But so we have people who are in the permanent resident pile that you're here legally, you come with all the right papers, and you still have to wait 3 months to get a health card. That's true for Quebec, British Columbia, and Ontario, the highest provinces to receive immigrants. Now, post-COVID, nobody has said anything out loud, but it seems like the PR wait time might not be in place anymore. People are too afraid to outright ask, but it was suspended during COVID and it doesn't seem like it's come back yet. Many people are failed refugee claimants, contrary to our reputation. And if you look at documentation from the UN about Canada, we are being criticized because we are considered a humanitarian country, and yet we're taking less and less refugees in proportion to applications and in proportion to the number of refugees on a global scale. Um, and then we have this growing category of people who are just undocumented. So failed refugee claimants, guess what? If you put in a refugee claim, you spend money, you wait 2 years trying to get your claim to go through and it gets rejected, you're not getting on a plane and going back home. You're trying another way to stay, whether it's a work permit or a temporary permit, a student visa. So we have more and more people trying to get legal access to the system with more and more barriers in place and massive wait times. And so, um, there's lots of terminology about what we call these clients. Really, what we know is that there were very few systemic responses. And so the healthcare industry, social services, the issue is being downloaded onto the provider and onto the patient instead of the system dealing with it. Some people use non-status, some people use precarious. I like the term illegalized because these are not people who want to be here illegally. They actually want to be here legally. I really more and more, and I think especially in our current global climate, having worked with both government assisted refugees, so people that we bring out of camps or out of war-torn countries, so legitimate versus the kind of non-legitimate claiming through other routes, there's no difference. We are talking about refugees. We're talking about people who are displaced and stateless and running from something. Nobody is like, I'm pregnant. This is a great time to travel around the world and displace and uproot my whole life. That's very rare. So I'm saying that because I also am kind of calling on midwives to start using the terminology of undocumented refugees. So what is it like if you're undocumented and you're trying to get healthcare? And many midwives who've worked with this population are familiar, but it's a maze and it's a mess. So many people start at walk-in clinics because you'll just see a sign and be like, okay, there's a doctor. You might pay and get sporadic care. So an ultrasound, they're not going to see you ongoing. You might get some tests done. And then usually they're like, you need to go to a family doctor or an OB. Family doctors, there were few and fewer and fewer providing obstetric care, and even less providing obstetric care for people who are undocumented. That's kind of generally family doctors who work at CHCs or who take a couple of clients pro bono in their call group. Most people at some point end up at the door of an obstetrician, and I don't even know what to say about retainer fees anymore. Like, in the post-COVID reality, and what lots of midwives are seeing is that the numbers of what hospitals are now starting to charge clients are outrageous. And it used to be $3,000 upfront to the OB, then $5,000. The latest ridiculousness I heard was from Ottawa General Hospital that wants you to put $20,000 down as a deposit for your $40,000 bill. The problem with hospitals is they are all using the rhetoric of obstetric tourism, and we have to get them to stop and just be like, great, yes, obstetric tourists, charge them a fee. We're not talking about that anymore. We want to know what your plan is for all of the undocumented people that we also know are in your backyard. Because every time we engage with the obstetric tourist narrative, we make it sound like we are taking obstetric tourists when we know that that's not the majority of people that we see. And we're allowing them to co-opt the whole conversation. It's like, um, anyway, it's ridiculous, and it's just a circular argument. And if hospitals are saying more and more, using the rhetoric of equity and making us do equity surveys, and yet only defining this population as tourists, they're not actually being congruent with what their equity principles are. Um, Many OBs are full or just too cost prohibitive, and they're becoming more cost prohibitive as hospitals are taking over, being the keepers of the money. Um, Midwives are often full. And initially, back in 2012, when this program started, we did not have funding for consults or transfers of care or diagnostic tests. If you're lucky, you could end up with a CHC, and then you're covered for diagnostic tests and consults, not for hospital fees. But many CHCs have lower arrangements with hospitals around fees. They're mostly full. So really, you end up with people coming to the non-insured walk-in center exactly the way the research says that we see uninsured pregnant people. And that's not just our research, but research on uninsured people in pregnancy in general says that people have inadequate care, care later in pregnancy, and less care overall, or no prenatal care at all. And that certainly is what we see. So we kind of had this marriage between the community health center and the midwives. So with us being specialists in perinatal care, one, we offer choice of birthplace. That can be ethically concerning with people who are choosing to birth at home, not because they want to, but because they feel like they have to. And I want us to just think about that for a second. We all, I hope, believe in home birth, think it's a great thing. Imagine being in a country where you are forced to give birth at home because the hospital is bankruptcy. That, like, even imagine the average Canadian being forced to birth not at a hospital. It's really obscene. Um, so we have the knowledge, we have choice of birth options, but we didn't have funding in place for consults. We did have access to hospital inpatient, outpatient programs and urgent care without having to send people to the ER. The community health centers had arrangements with some hospitals around cost and funding for consults, as well as the infrastructure. So they were already running a non-insured walk-in clinic starting in March 2012. And they realized very quickly 30% of their clients showing up were for pregnancy related concerns. And they just didn't have the referral base or the knowledge base to deal with that level of demand. So we started, it's now on Thursdays, but Midwife Mondays just has a better ring to it. So we did a retrospective chart review, and I am going to just go through some of our preliminary findings. I'm just gonna check my time here. Okay. So we looked at all clients that had midwife encounters over a 10-year period. Our total numbers are around 1,182. Those were analyzed in depth in terms of demographics. Those were analyzed, but not as in depth. 495 have been analyzed in depth, and really, that's just because of the torture that retrospective chart review is. After the funding study, after I did the study that got funding in Ontario to get increased for this population, I was like, I'm never doing a retrospective chart review again. And here I am. So we did all of our charts and realized that there was a bunch of data missed. So we are in the process of going through all the charts again, hence only at 495, but some of the numbers are 1182. Again, we're not looking at outcomes. So one of the flaws of the research is that once the client is hooked up with an obstetrician or a midwife, or whatever the pregnancy outcome is, we don't know what happens once they move on. So it's kind of referral patterns and risk level. The immigration status of our clients, this is not necessarily indicative of who uninsured clients are. because the criteria is that you kind of have to be non-status to access the clinic. And so obviously most of the people we see are non-status. There are growing numbers of people in different categories. So a really good example is historically we've thought of people on student visas as not being residents. And that was with the idea that student visas generally were for the globally elite, like university fees, foreign fees are very high. But that's not the reality of most foreign students anymore. Most are coming through questionable colleges. Many are coming with fake colleges. 900,000 Punjabi students have just lost the promise of a work permit. So when you come here on a student visa, and why so many people come, is you then get a 1-year work permit, and then you can follow that up with a second year. I know this because I have family members who've done this. And then if you get a job, you can apply to stay. So people do come as a pathway to PR. And all of those 900,000 students that have lost their work permit are not going to get on planes and go back home. They're going to try to figure out a different path to stay or hope that the government or policy changes. Age is pretty much what you would think. So most people are kind of 26 to 30. And then it decreases the younger people get, and it decreases the older people get. So very few between 46 and 50. And I think, a handful of clients between the age of 10 and 15. We've never seen anyone younger than 15 at the uninsured clinic. That's not for any reason other than not presenting. Regions of origin. So 47% from South America, not surprising. The highest places are South America and the Caribbean. And that's because you can actually get here. It's just proximity. And I remember, or it's easier to get here. Not that it's easy at all, but I remember when I was doing work with Syrian refugees, having this epiphany and like, oh, there's no great love between Syria and Greece. You can just get there. And it's the closest way to get out. And, for us, especially as the United States becomes more and more hostile, it's likely more people will go north instead of going back south. The vast number of people from Asia were permanent residents, and that is because it's very hard to get here with all the, checkpoints and visas that you need without some kind of status. I just want to give you a little bit of hold on, I have to move everyone's pictures here. I just want to put this in context a little bit. So Mexico right now has a cesarean section. Oh, sorry, 28% of our clients come from Mexico, 13% from Brazil. Those two countries are among the top 4 of all cesarean, of the highest C-section rates in the world. Brazil is number 2, only second to Dominican Republic, which is number 1. Mexico and Brazil fight for number 1 in the elective C-section category. But what this means is that 25 to 35% of the clients we see over the 10-year period have had a previous C-section, and that number is increasing as the number of C-sections increase. I also want to point out, and this really makes me sad, but there's an increasing trend towards classical external incisions. And for people working, especially with clients from Mexico, but across South America, and it will probably spread really quickly, there's this new trend where if you're in a public hospital and you can't pay for a cosmetic cut, is what it's called, then you will get a classical external incision. This is blatantly punishing poor women for being poor. They are still getting internally, and I know there's through fellows I've been involved with and like word of mouth through people who work in the Mexican context. Very rarely is it a classical C-section. It's still internally a low segment cut, but without an operative report, how is anyone going to know that? And this trend of classical external incisions is just increasing. I'm even afraid to say it out loud in Canada because I can see it increasing all over. So I want us to think about the trend increasing of C-sections overall, especially from our part of the world south. Trend for more classical external incisions and no operative report. And actually that VBAC rates, especially in South America, but even here, are declining, even among midwives. And so the sad reality is that I can much easier get a client in with a provider if they want an elective repeat C-section. I also just wanted to put this in the context of interpretation services. So half of our clients need interpretation, and the vast majority of those are from Brazil and Mexico and also Portugal. So the top languages we use are Mexican and Portuguese. Brazil and Mexico, again, also with the highest rates of C-section, needing interpreters more for these clients. Think of what that means for informed choice discussions or discussions around VBAC or the conversation around risk. And I think, you know, fighting so much for clients to have access and equity in the system becomes so tiring that to also fight for people to do what's evidence-based but not normal in our system becomes taxing. And I think, you know, we have the capacity to do it less and less, or the reality is we're doing it less and less, making referrals for elective repeat C-sections much easier. Just a little bit about relationship status, because I know there's a lot of narrative about, you know, what kinds of people are undocumented. The vast majority of people are in relationships. I circled the unknown because, especially for people where it's not necessarily a planned pregnancy, many people, and you know, we all know people or have been those people, that, you know, many people who are unexpectedly pregnant are also in this point of deciding, are we fully committed to each other or not? So I think when people say unknown, it's really unknown. This I also wanted to point out. So this is, and I gives you an idea of what the income is of our clients, or what the reported income is. And I want to point a couple of things out on this. So the vast majority of people live well below the poverty line. I want to point out the unknown. So 617 people, so more than half, said that their income was unknown. And I know that that can be seen or interpreted as people lying, but actually I think it's, my experience is that it's truly they don't know. You're precarious, you're trying to get status, you're trying to get work, you're trying to go from one job to another and figure it out. And so actually many people don't know what their income is going to be or what it is. It's very variable. What I do think is marked to note from here is 27% of our clients live on a household income of less than $15,000 a year. 40% live on a household income of less than $35,000 a year. The average number of people or the average household size of our clients was 4.4. So when you look at the poverty line, or what's based on the market basket measure, the poverty line in Ontario for a family of 4 is considered $58,000. The deep poverty line is considered less than $43,000. And I want you to just think about how much lower these clients are, even than what we consider deep poverty. In terms of racial identity, I think this is really important. 59 out of 495 identified as white European. There were like 3 people from North America, a couple of Canadians who had lost their health card because they had lived abroad, a couple of people from America. It's interesting that of the 59 who identified as white European, half of those were from Brazil and half were from Portugal. And I just think that's an important thing to note in terms of what our ideas of whiteness might be versus what other areas of the world and their ideas of whiteness might be. But the most important point here is that 88% identified as racialized, either from Asia, whether that's South Asia, East Asia, Southeast, identified as Black, whether that's Black African or Black Caribbean or Latin American. And I cannot stress enough how much being undocumented is a racialized issue. And I think that's a really important piece for us to remember when we're talking about equity. So what are some of the other results? The average gestational age that people came to see us, the range was from 2 weeks to 41 weeks. We actually had one client who presented at 43 weeks, but she hasn't been captured in this 495 so far. She will be in the final. Most people came at around 16 weeks. So that means missing the dating ultrasound, missing first trimester screening, missing the option of medication abortion for first trimester. And also many practice groups and OBs are already full by that point in people's gestation, with midwives having less and less capacity as they're facing their own HR crises at their own clinics. It's important to remember, and I talked about this with the VBAC, but the focus becomes about access to care versus choice. Because one, if you don't have a care provider, you don't really have any choices. But so it has to be about access, but it is a different spin on midwifery. And it's something I've been thinking about as I've been looking at this data, is like, how do we provide better midwifery kind of care, like longer visits and seeing people more? It's not necessarily desirable for people who have to wait. Like, so sometimes when people come to see me, they wait an hour. Sometimes they wait 4 hours. Post-COVID, when hospitals started to, like, all of a sudden when it got announced and everyone got dropped by their doctors, we had people showing up at 4 o'clock in the morning, hoping they could see me by 8 p.m. Like, it's just dire. The average gestation was 2 previous pregnancies. The TPAL, I got completely confused with the statistics and could not figure out those numbers for this presentation, so I'm sorry. But the average client had 1.7 children, so most are multips. 31% had previous prenatal care, with 70% of those people having prenatal care overseas. So that also shows that when people are undocumented in Canada, they have less access to care. 70% of people did have records, which is very helpful. And most of those were people from overseas, actually. What about substance abuse and some of the other markers? I think it's really important, again, one, we were also to keep in mind that there's underreporting, but the vast majority of people we see do not have issues with addiction. And that is my impression, as well as what the data is saying. 9% were smokers of nicotine, with 91% of those reporting stopping with pregnancy confirmation. Only 1% alcohol use and 1% marijuana use. Half of each of those also stopped with pregnancy confirmation, and the other half did not. So the risk assessment, I think this is really important when you're thinking about funding a program like this. The vast majority of our clients are low risk, something, I think it's 78%. Medium risk was considered di twins, having one previous C-section, GDM, like not requiring insulin. High risk would be things like, hypertension requiring medication, gestational diabetes requiring medication, 2 previous C-sections. We put as high risk, even though we were like, should that be medium? And unknown, which was very few, was for people who had things like placenta previa on discharge at 18 weeks, or query IUGR at a 32-week ultrasound when we've discharged them. But the vast majority are low risk. Trajectories of care. So 78% of all clients were sent to midwives. Only 2% were lost to follow-up, and that's something I'm really proud of, is that we are really good at hooking our clients up with providers. Like, that is really the biggest success, I would say, of our program, is 98% of people get hooked up with a primary care provider. The vast majority, it's a midwife. Sometimes it's an obstetrician. 18% of the time it's an obstetrician. Midwife and OB, so 2%, our highest risk clients often were midwife and OB, because the midwife could triage them that day or within the next day. And so I think that's something that's really interesting, is actually that the highest risk went to both, because that was the easiest and fastest access in the system. Less than 1%, so 4 people in total, were urgent referrals. 2 of those were to labor and delivery, 1 for term prom and 1 for PIH. 1 for term prom, like after leaving the airport, they came to see me and she had prommed on the plane. 2 to ER for antenatal hemorrhage. And I'll get into the story a little bit later, but what's important to know, both of those antenatal hemorrhages were for retained products. Both had been referred to the hospital one time previously, and they'd been stabilized and sent away without any further follow-up. And one was sent to the hospital 4 times. And we'll get into that story. But what's interesting is both these people ended up at the same hospitals requiring urgent surgery. One almost died, which is a massive miss when these are people that have interacted with the healthcare system and still been turned away. I just want to go back to that for 1 second. That also really shows the NIMBY syndrome. Like, there is such a not in my backyard syndrome when it comes to hospitals and this population, where they're all just like, don't bring them here, as if these clients don't live in the communities that they serve. What were the kinds of complications? So again, it's important to note that the vast majority had none. 74, the most common complications were UTIs. I think 43 of those were GBS bacteriuria. 31 PIH requiring medication, 12 GDM requiring medication. Chlamydia is 15. My suspicion is it's actually much higher, but because midwives couldn't treat chlamydia for so long, those people would often be rostered on the nurse practitioners a day. Missed abortion, 10, and other complications, 18. So those would be things like sickle cell, severe thrombocytopenia. Those are just a couple that are coming to my head. And then this is just my last couple of slides. So there's a really good cost-saving argument here. Like, if out of just those UTIs, if you save 1 micropreemie or 2, or 1 baby is prevented from having lifelong neurological consequences related to GBS sepsis, that's enough to justify funding a program like this. So I'm going to just tell a couple of really quick stories. I probably won't tell all 4 because I want time for questions. I'm going to just tell one story. I'm going to tell the story about the client who went to the ER. So this is Brenda. She had severe hyperlipidemia, probably a genetic condition that had made her get severe liver issues and pancreas issues. And she was a very, very high risk and had a missed abortion. She was bleeding and sent to the ER. They said, oh, you're having a miscarriage. It doesn't matter. Didn't have an ultrasound, nothing else. Didn't check for retained products. Sent away. Started bleeding again. Went back to the ER. Again, was told you're having a miscarriage. No ultrasound done. I think that time she did have an ultrasound. Sent away. She's very high risk. Her blood sugars come back off the charts. I get in touch with a doctor at Sinai. I'm like, listen, this person can't just be medically managed. They need to have an obstetrician following them. Can they come to the EPC? Sent to the Sinai EPC. It's run by nurses. They wouldn't take our billing letter. She this person ended up going to the ER and the early pregnancy clinic at 2 different hospitals 3 times. And every single time, everyone turned her away because there was not the right billing letter and she couldn't pay the hospital fees. She ended up having such a massive hemorrhage on the street as she was getting off a bus that she passed out. Someone on the street had to call the 911. She was taken to hospital unconscious. She had a emergency surgery, massive bleed, blood transfusions, and it was at the same hospital where she had already been turned away 4 times. Nobody can tell me that that is a cost-saving thing on our system. Just some final take homes. Like, we're talking about people again that the research is showing to be the most vulnerable. And we have enough research in Canada that says the same thing about this population over and over. There is no research to show that we have hundreds of thousands of medical tourists here. That's not who we're seeing. Remember that this is a racialized issue and this is a gendered issue. Even in the most privileged clients I've ever seen, it is very rarely a woman with her own financial resources and her own autonomy deciding that they want to come here just because they want to have a baby here. And I just want us to think about that in terms of marginalization and choice. And that's not the pregnant people that we're seeing. I also just wanted to end by saying, like, the idea of having free reproductive health care is not crazy. Most European countries, because they have universal health care, if you're there and pregnant, you can access the system. And then I just wanted to say, like, we are at a point of humanitarian crisis in this country. And the next 4 years are looking really grim. And I think we have to be armed with the right information and messaging. And that is it, which gives us very little time. No questions if we have time.
Wow, thank you so much, Manavi, for that really powerful presentation. It's really thought-provoking to think about the challenges that are facing this population and the difficulties in healthcare and in midwives trying to respond to that. So thank you for all of that. If you want to ask Manavi a question, I just ask that you put it in the chat and we can follow them down from there. Simone has a question for you. She says you've collected amazing socio-demographic data, and she's curious where you collected it, on OPRs, on some kind of client survey provided by you or the CHC, or on a certain type of EMR form.
So that's a really good point. The CHC collects this demographic data as part of their ongoing research. Like, everyone signs a consent form when they register. And so they also ask people questions like sense of belonging to community, sense of physical health, sense of mental health. And one of the things I found really interesting is that there are many people who have a strong sense of belonging here. So we are talking about people who live here. But yes, this would be really hard to capture in a regular midwifery clinic without people filling out a different form.
Yeah. Okay. Also, folks, if you have questions, you can raise your hand and ask, on audio. That's fine too.
And I just have to do a shout out to Karen Sundarajan, who's here and has been working with me doing this painstaking torturous. It is fascinating, but it is just painstaking to go through all of these charts. But it's also like a flashback of the last 15 years of my life. And realizing, even though things seem really grim, I don't know if this is a good statement or a bad one, they've been pretty bad the whole time. Like really, this is an area that we have not paid attention to. One of the things that was the most alarming for me is 3 months of the year, I take global health I take obstetric fellows who are doing a fellowship in global health, and they'll come rotate with me at the clinic, and then they're kind of on call, or I can contact them by text throughout the year for more complicated stuff. I've had 4 students in a row from the United States, and these are people who are obstetricians, they're doing a fellowship, who were shocked at the state of uninsured pregnant people here. Like over and over, having students from the state saying this would never happen. There's always somewhere for people to go, even if it's not great. We don't even admit that we have a problem.
Wow. It sounds like there's so much advocacy that needs to happen.
Oh man, it's so much. And I
Yeah.
do feel like as midwives, like I do think, and I see the massive push we're getting from hospitals. I just think we say the same things over and over. We don't take care of tourists. You know, have I seen the occasional tourist? Sure. Have I seen someone who like has millions of dollars and on their own agency is like, I'm so wealthy and independent as a woman that I'm going to come here to have a baby? No, I've never met that person. I don't know, like, other than being North American, if they exist in the world. Um, but really, like, it's just so interesting as the world is creating the crisis of displacement, either through climate or war or all of the above. At the same time, the countries are like pretending that their borders are some sacred pre-existing manifest destiny, when actually, like, we are seeing the fallout of a system that has used human beings and land as capital. And it is really more and more, I really feel like we are in a world where more than ever, politics are fought over the boundaries of women's bodies, and we can't have that happen anymore. Mel, I think someone had put their hand up.
Oh, you turned my camera. I mean, honestly, Manavi, I'm just here full of gratitude for you doing the work that you do. I really just wanted to say that out loud. I feel like I'm going to cry. I came here today to hear about people doing the good work because I think we need more to be surrounding ourselves with, you know, the good people doing the good work. Sorry, I'm feeling highly emotional, but just, thanks, Mon. Thanks.
That honesty is so lovely. And really, that's what midwives have to remember. Like, I always say that I'm the like face and the voice, but who's doing the on the ground work are the midwives that I'm referring all these clients to. A huge proportion of that, just from my experience, has been West End midwives and how much they've been committed to this population. And I just think we have to just like the same way the hospital keeps talking about tourists, we have to keep talking about marginalized people. Like, it's a stupid conversation because it's not going anywhere, but they want us to fold into the tourism rhetoric. And yes, we have all met those people who are like, I'm having a baby, I'm going back home. Usually we don't know until, after they deliver or something. But um that's not the majority of people we see. We're seeing people who, to actually decide you want to live here undocumented is a terrifying thing. We are freaking out about ICE showing up in schools in the United States, and so far they've been turned away by principals. They did the exact same thing with the Harper government in Toronto. It's why the TDSB adopted a don't ask, don't tell policy. And that is because we, the areas where they had a high migrant population, schools were empty. Because what they did is if they take your kids, they know that you're going to show up. And that's why that's the strategy. And so I remember when they did that here, showing up in clinic, and we were all like, what is what? Like, nobody was showing up. Our clinic was empty. Schools were empty. The whole like sector of our city was empty. We were like, what is happening? And it's because so many people were absent. They were like, if we know one person in our family or circle that's undocumented, they're threatened. And we're coming back to a world where somehow we think we are more deserving of the stolen land. Oh, this reminds me of my last slide. So we often say no one is illegal on stolen land. I actually think most of us are illegal, actually. Like if we're living here on broken treaties and stolen land, most of us are illegal. And if that's the truth, then who are the people we should be asking whether others are allowed in this country? I don't think we're asking the right people. And Indigenous people are not the ones who are complaining about immigrants in this country. It's kind of flip sides of the same undesirable coin of non-whiteness, really. Anyway, keep the proud
Interesting.
people.
There was one more question, Manavi, about whether tourists can have access to midwifery care in Canada, because they were thinking that midwives in Canada are only paid by the government.
So listen, no, technically, even forget being undocumented or not, our TPA agreement says that we care for residents of the province. Now, what that means legally is the intention to be a resident for 6 months. So you can come 2 weeks ago, but if you have the intention to stay for 153 days, which is what the OHIP card says, then that's all you need to know. We don't need to police people. The AOM's position is actually that if we know someone's illegal because we're their healthcare provider, we are not allowed to tell the government. So I will, once in a while, if I'm like, you're really a tourist, I'm like, you've got to pay for care. Like, I don't know what you thought was going to happen. But listen, I also had a client show up, and one of my examples I was going to give was a client at 38 weeks, 3 previous classical C-sections, and she landed at 37 weeks. Now I'm like, what are you doing? But why does it matter? Like she showed up and she's like, I need a C-section. And I've gone to the hospital 3 times and they keep telling me to come back in labor for somebody who should not labor. So at some point I'm like, I don't know. I'm not an immigration officer. I ask people the way midwives do. We do our due diligence. That's it. I'm not policing you beyond that, nor do I think that we have an obligation to do so.
Yep. Okay. Well, thank you so much for presenting this very powerful work to our audience and for your leadership in this area. It just sounds like something we need to advocate so strongly for.
Yeah.
So thinking about our next MMRC seminar, folks, please join us next Wednesday, February 26th at 12:30 Eastern Standard Time, when Alison Campbell will be sharing their research on parenting behind bars, maternal-child connection and separation in BC's correctional facilities designated for women. So hopefully we can see you at that. You can get more information on our speakers and schedule and watch recordings of previous presentations on our website at www.mmrc.mcmaster.ca. And we also have an exciting new podcast series called Conversations on Midwifery, Experiences, Education, and Evidence, to help you stay up to date on the latest evidence-based practices, shine a light on innovative approaches in the field like Manavi's, and most importantly, provide a platform to share the common experiences that make midwifery unique. You can find the podcast on Spotify, Acast, and Music, and we'll post a link in the chat for that. And other than that, thanks very much for joining us. Wishing you all a great day and hope to see you again in February for our next seminar. Take care.
Nice to see some of your faces. Hi. Bye, everybody.